All right, folks, we're going to get going here just because I'm actually in kind of a time crunch today. Dave let me know about 40 minutes ago that he's got a meeting with AOMP about fellowship program stuff. So he's not going to be able to make it. And I'm kind of in a bit of a time crunch. I'm supposed to be leaving town here to go to a travel tournament with my son and shortly. So we're going to be probably cutting things a little short today, just from a time frame perspective, but we do have some time here to answer questions. I have a couple things that we can go over if we don't have too many questions, but if you have anything that you want to ask about, now would be a good time. Anybody? Kind of a thin group today already. Nothing? Okay. Well, what we're going to do then is I'm just going to have to start picking on people, um, asking some questions here. So first thing, let's see, who do we got here? Who wants to answer some questions? Kristen, you there?
I'm here, Eric.
All right, let's do this. Let's go over just some concept stuff. Okay, so I want you to think about what the differences would be in objective findings for a radiculopathy versus a segmental facilitation. How would those two be different if you're looking at them in clinic?
So with a radiculopathy, you said objective, right? Not subjective.
Yeah, well,
Um,
we can talk about subjective later. Let's start with the objective stuff.
so for like a segmental facilitation, you'd probably see um like more of a brisk reflex, like brisk reflexes.
Okay,
With
good.
radiculopathy, um, like you could kind of see less of or hyporeflexia with a
Correct.
so that's reflexes.
Okay.
Um, Probably no dermatome changes for a segmental facilitation, but you might have some changes for a radiculopathy.
Okay, how
Um,
so? What would the
my
change be?
Say that one more time.
What would the change be for a radiculopathy?
Probably like reduced light touch, reduced pinprick.
Good.
Myotomally for segmental facilitation, you might see more fatigable weakness.
Wait,
Radiculopathy.
say that again. For segmental facilitation, we'd see what type of weakness?
I said fatigable, but now it sounds like it's not a fatigable weakness.
Now think about that. What type of issue leads to fatigability in force output testing?
I guess it would be more of a radiculopathy for fatigable weakness because
Yeah,
the nerve is going to be affected, so that'll affect the myotomy you're testing.
correct. Okay, so then what about facilitation? What type of weakness would we see there?
A non-fatiguing weakness.
Non-fatiguing. Yep. So consistent weakness with what type of characteristic? There is one characteristic that we've been talking about pretty consistently when we've discussed facilitation.
You could have like more of like a braking weakness, like if you go on to test more like the force output. So if you put more force into it, like the quick braking weakness,
So it's speed dependent.
speed dependent. That's the word I was looking for, Eric.
Yep, yep. So we call it velocity dependent weakness.
Yes.
Um, Basically, the two differences that we have between, or the major differences we have between a radiculopathy and a segmental facilitation is that a radiculopathy diminishes everything. Everything drops down. So hyporeflexia, hypoesthesia, and then fatigability as far as weakness goes. With the segmental facilitation, everything gets wound up. Okay, so it goes the opposite direction. So motor tone increases, right? We have increased motor tone, which leads to things like trigger points and sensitivity to, you know, palpation and things of that sort of nature. But the increase in motor tone is actually what causes the speed dependent weakness, right? So what it does is it affects the Golgi tendon organ, right, which is basically a fail-safe mechanism that senses the amount of tension that's going across the muscle belly or the entire contractile unit. And if there's too much tension, and essentially too much tension that builds up on that muscle too quickly, okay, and that's the speed-dependent component of it, it just shuts the muscle off, right? So I always use this stupid example, but if there's a bowling ball on a shelf up high that's going to fall off, and I go to try and catch it, and it's too much weight, too much tension, too much essentially too much load being applied too quickly to the muscles of my arm, the GTO is going to trigger that automatic inhibition. It's going to shut everything off to prevent any type of structural damage so that the tendon or the muscle belly doesn't rupture, right? So that's the change in tone, is that it's increased. Same thing with sensory feedback. It's not necessarily what we would call hyperesthesia, but we can have a hypersensitivity to non-painful stimuli, right? So it doesn't necessarily mean pain. It's not like a you know, RSV or any of those sort of things where we end up with um, complex regional pain syndrome or any of that sort of stuff. But there is the potential for increased sensitivity throughout that reference pattern in the dermatome. And then reflexes, same thing as with the motor tone, is they'll be ramped up. That's why we have brisk reflexes are slightly increased. They're not hyper reflexic, right? We don't have clonic beating with that or any of that sort of stuff. It doesn't radiate down to the next joint, but we can certainly have a brisker reflex through that particular myotome dermatome, right? So that's the biggest difference, is if we look at facilitation, it's exactly what it sounds like. Everything gets facilitated. It goes upward, right? Radiculopathy, everything drops down because we're losing motor conduction, motor and sensory conduction. Does that all make sense to everybody? Any questions about that? From a concept standpoint, should be just a review at this point. All right, pretty good though, Kristen. Let's see, what's next? Who do we got here? Patrick, you there?
Yeah, I'm here.
All right, ready for a question here? Just from a concept perspective.
Sure.
All right, let's do this one. Thinking about a degenerative process like osteoarthritis, why don't you try and tell me about how that degenerative process becomes a self-perpetuating issue? Meaning, once it starts, how does it kind of snowball until we end up with a joint that, may need to be replaced? Any thoughts on that?
Sure. So if you have kind of like initial osteoarthritis, some inflammation in the area, maybe that kind of aggravates some of the surrounding tissue, the body's going to kind of subconsciously avoid the area, maybe decrease weight bearing. But for any healing at the subchondral bone, you want weight bearing. So if that inflammation then just kind of stays in the area, you avoid putting pressure. The subchondral bone's not getting any pressure. The arthritis is just going to get worse, and then that just kind of keeps going.
Yeah, that's pretty close. There's more detail to it, obviously, than what you've got so far. But the first thought is the inflammation is what kind of kickstarts everything, right? So if we look at, a traumatized joint, say that we have somebody that sprains their knee, right? The first thing that happens is we have inflammation in the area, right? The inflammation, just like you were saying, tends to limit our ability to move the knee through a full excursion of motion. Inflammation tends to stiffen the connective tissue around the joint, particularly the joint capsule, right? So when that happens, we're limited in kind of the end ranges of motion. Now, if it's the knee for a capsular pattern, we're going to be more limited into flexion than we are into extension, but we will still proportionately have some limitation of extension. The terminology that I think we need to use here is habituation. Okay, so habituation is the process by which we close pack and approximate a particular joint, particularly in weight bearing. Okay, it can happen in upper extremity joints as well. But in weight bearing joints, so like the knee, the hip, etc., Habituation is the process when we get to a closed pack position. So for the knee, it's full terminal knee extension, right? For the hip, it would be extension with conjunct internal rotation. But what that does is there are channels within the joint surfaces, so within the articular cartilage, subchondral bone, etc., that need to be opened in order for us to force the synovial fluid into those tissues. Okay, the synovial fluid is actually what carries most of the nutrients that are actually supposed to support the health of that subchondral bone and of that articular cartilage, right? So these channels, they lay kind of in this sort of scenario here as we squeeze the joint tight, right? As the connective tissue tightens up, as the articular surfaces compress and become tighter, what happens is these channels twist open, okay? And these open spaces that are then exposed flush in some of the synovial fluid and the nutrients that go with it. So that's what's supposed to help keep the articular surfaces of the joints healthy. The problem with a capsular lesion is it limits our ability to get into that full closed pack position, right? So we're unable to open those channels effectively or completely in some situations. And so what ends up happening is the articular surfaces start to degrade, right? And so as those things start to break down, we get thinning of the joint line, right? So all the joint space will start to thin down. That essentially slackens off the supporting connective tissue, the ligament structure, the joint capsule, etc. And now all of a sudden we have like a flat tire situation where everything's kind of thinned down, and all of a sudden we have these abnormal articular shears that are going to be permitted within the joint. Those sort of situations when we have these kind of linear non-physiologic motions occurring, they beat up that surrounding connective tissue. We get additional inflammation, we get continued restriction of the joint mobility, okay, which then further perpetuates the loss of habituation. So it does tend to kind of snowball in those sort of scenarios, right? As soon as the joint stiffens, it's going to go on this path, right? And so this is why regaining and maintaining range of motion after a trauma is so important, because we have to be able to have that in order to keep the joint surfaces healthy. Okay, so it's very much one of those situations where once it's started, the process just keeps going down that track. There are typically 3 phases to any osteoarthritic change. The first phase is usually not very detectable. And it's not often when we see patients. I mean, if it's a post-trauma thing, then maybe we do. But if it's a kind of slow onset or slow deterioration of a joint, and the joint has started to stiffen as a result of that, we may not see people in that first stage. The second stage is the one that we typically will see. This is the person that just has a stiff, articular joint. So that's actually the phase of osteoarthritis that PTs will tend to have the most effect on, is that second phase. The third phase, it's pretty much over by then for them. This is the phase where the joint surface has really broken down to the point where we're getting pieces of articular cartilage and whatnot breaking off. This is kind of the phase where people get those little joint inclusions and things like that, joint mice floating around in there. Tends to be very painful, tends to be very sharp and debilitating pain when those things get stuck inside the joint. But by then, really, the joint needs to be replaced, or there needs to be some sort of other surgical intervention done to help kind of get the person past that. Okay. But pretty good, though. I like your head went right to the spot that we were thinking, that we should be thinking. So that's a good start. Any questions about that? Anybody? No? Okay. So basically, if we have somebody that comes into the office with an osteoarthritic joint, right, the priority is trying to regain the closed pack position of that joint, right? Because if we can do that, then we can help prevent further breakdown. We can, especially if we can regain capsular mobility, right? So these are the type of things that we have to start looking into as, how do we prioritize what our treatment mechanisms and processes are going to be for these types of people, okay?
Hey, Eric, real quick. Is there
Yeah.
a way to know what phase they're in?
No, not necessarily. I mean, honestly, if you get them, and as long as they're not in the third phase of that sort of scenario, there's still plenty that you can do for them. The first phase is usually when there's still this very minor amount of inflammation. And again, if it's a trauma, right? So if this is a person that comes in that got, slide tackled playing soccer and they sprain their knee, the knee is going to be hot and swollen. And so that's the instigating process. So we'll notice that, right? That's kind of the first phase, is that early inflammatory phase. But if this is a situation where the knee is just kind of slowly taking a pounding over time, we may not notice the beginning of the inflammatory process, just because it's going to be relatively small micro traumas to that connective tissue, right? But as those things start to add up and those cumulative sum issues start to build, eventually the joint's going to start to stiffen. And that's usually by the time they notice that it started to stiffen, they've already transitioned into the second phase. So if somebody comes in and they just have a stiff capsular knee, a capsular pattern of the knee, they're probably in the second phase, barring them having had some sort of, recent trauma to it. Does that make sense? How many of you here have probably felt this? And this is probably the most conclusive version of phase 3, the third phase of osteoarthritis, the breakdown of a glenohumeral joint, where you start kind of moving them toward, a 90-90 position, and you start feeling these clunks and catches and shifts and all these funky things. And it just feels stiff, but then it also feels like it's just moving around, shifting around within that glenohumeral joint. That's what I liken to if you felt that, and I think most people have at some point in their careers, that's what I most liken to the third phase, right? This thing that just feels completely unstable, but it doesn't actually move very well. It's because the external tissues, things like the joint capsule itself, don't move well. They're still stiff. They're still stuck in that capsular pattern, but the articular surface underlying that is unstable because it's thinned out so much, because there's been so much breakdown of that articular cartilage, right? And these are usually the joints that they're pretty painful, right? When that sort of stuff happens, because now we're irritating the subchondral bone, which has a ton of nociceptors, and is very capable of producing pain, versus the articular cartilage doesn't have any of those things, doesn't have any nociceptors, really isn't capable of producing that sort of pain, right? Anything that produces pain inside the joint there has to be irritating the subchondral bone. That's how like a bucket handle meniscus lesion creates pain within the knee, is this thing flips up into the joint and then it compresses into the opposite side subchondral bone, right, through the articular cartilage. So that's how that happens, and that's how that produces pain. It's not the tear itself, especially if it's a mid-body tear, right? If it's a radial tear that actually extends into the periphery, where we have kind of that blending of the coronary ligaments, well, the coronary ligaments have nociceptors, right? And so that's why peripheral tears tend to be painful, but the mid-body bucket handle type tears, they're not, unless they're impinging into the articular surface. Okay, are we all comfortable with that idea? I will take your silence as a definitive yes.
Yes, Eric, comfortable.
Thanks, Kevin. Now that I know you're here, you can answer the next question. This is a good one. So how can you potentially diagnose slow flow axoplasmic loss, axoplasmic flow loss? Got a thought on that, Kevin?
I'm thinking
Muted.
I would look for, so I started thinking about force output testing, kind of the quality of that.
Okay.
So I'm looking at consistency of force output over, 6 reps or so. I
Okay.
think what I would see in a slow flow situation is a pretty dramatic drop off in that force output by probably reps 3 and beyond.
Okay. This is
That would be one thing.
That would be one thing. This is kind of a trick question, so I feel bad for throwing this at you, but it is a bit of a trick question. What is slow flow axoplasmic the AXT slow flow, what does that do?
I think it's this lack of neurotransmitter binding. So we have the nerve, whether it's acetylcholine or whatnot, it bridges the gap, and essentially this transmission process is the slow aspect, thus the term, right? So like we're not getting this binding of the neurotransmitter on the opposite end plate to continue to conduct the signal. Do I have that correct?
You've got it partially correct. So that is fast flow, exoplasmic flow. So AXT fast flow is the flow of neurotransmitters down the axon. Okay. So when we have fast flow interruption, we've lost the ability to bridge that synaptic gap from one axon to the next cell body. Right. So that's fast flow. Slow flow is the flow of structural proteins. So myofilaments, all these sort of little things that help to maintain the end organ structure. So things like if you have a nerve that's innervating a muscle, it's what helps bring the actin and myosin and all the different structures, the different proteins and whatnot that make up the structure of that end organ. So a loss of slow flow AXT would end up degrading the end structure, which would be potentially muscle, tendon, etc. Okay, so you're correct in that that's the only way to test for it is to test the fast flow. There is no way to test for slow flow. Okay, we have to make the assumption that if we have AXT fast flow loss, so that's the fatigability component, if we have that, we have to suspect that we also have slow flow loss. So like I said, you're kind of half right in that you would have to test for an AXT fast flow loss, but we can't directly test for slow flow loss because all it is the end organ's structural, makeup. Is it still intact? But yeah, so you're correct in that regard that you have to test for the fast flow, and it should be a fatigable weakness, right? So if we have one axon that spits out a bunch of neurotransmitters, and we get a good contraction as a result of that, the next time it goes to try and spit out those neurotransmitters, there's not going to be any left, right? So it's very similar to a conduction loss in that sort of scenario. And these things are caused mostly by, moderate compression or multiple smaller compressions down the length of a particular nerve, right? So these are the sort of situations where we get into double crush syndromes and that sort of stuff. Does that make sense? Like I said, feel a little bad because it was a bit of a trick question for you, but your head was right in the right spot as far as AXT goes. You just got to make sure you differentiate between fast flow and slow flow.
Yeah, I'll be okay. My feelings are not hurt too bad.
Yeah, I didn't think
Your
so.
thought, the tissue breakdown part, you bring up an interesting thought. Clinically, if I'm suspecting tissue breakdown, but maybe I don't have a clear mechanism of injury, would that maybe point me that direction? Like, okay, this doesn't make sense. I'm seeing some tissue breakdown and I don't have a clear mechanism. Then maybe I'm starting to think I've got this AXT issue. Is that a fair thought process?
Absolutely. I would say when you start looking at patients that have maybe non-traumatic ruptures of certain structure, right? So we get people that have tears and stuff in their, common extensor tendon, things of that sort of nature. We get patients that maybe have non-traumatic tears of the hamstrings, et cetera. And it could be anything. It could also be, non-contractile tissues like ACLs and whatnot, right? So these sort of things, if you have non-traumatic issues that have resulted in significant structural loss or structural fatiguing loss, it definitely could be a consideration that, well, maybe we have something lurking here under the surface that kind of predisposed them to this particular type of injury, right? Because that would absolutely change some of your rehab components, right? If you had somebody come in that had, say, a non-traumatic Achilles rupture or something along those lines, and you're concerned about the potential for some sort of AXT issue, well, once they get into the rehab portion, right, once we start working on, strengthening things and getting movement patterns back and getting them to return to activity, if we have an AXT issue that might have precipitated that tear, well, we have to consider working on the things that may have caused the AXT issue, right? So whether that's a double crush issue, whether it's some slow developing, lumbar pathology like a posterolateral protrusion or something along those lines that's just it's not affecting conduction. It's not enough to affect that, but over time, it's enough to kind of slow down that AXT component. We may still find that as a fatigability. We may still find that as something that affects, the end organ structure. So yeah, absolutely, you can take that into consideration because it definitely should change the thought process you have when you're going through your treatment protocols. Pretty good. Any other questions about that? No? All right. Let's do something that's a little more clinically related here. Okay, so these other questions have been more about concepts and things that sort of nature. How do you apply them and whatnot? But let's think about from a clinical perspective. If we look at the common, or what you maybe call with the typical posterolateral disc protrusion in the lumbar spine. Okay, what is the common clinical scenario, the presenting scenario that patient would have as they walk into the clinic? Anybody want to take a swing at that? You got a patient that walks in the door. What do they look like?
I'll try, Eric. Depending on how acute it is. So is it an acute disc?
Yeah, acute enough that they're searching out help for it.
Okay, well, so depending on where it is, if it's like in L5, they're gonna have pain down the back of their leg, probably past their knee and into the calf. Depending on how severe the pain is, there'll probably be an antalgic gait. They may be shifted one way to avoid the pain or whatever their position of comfort is. I mean, I think that flexion probably would hurt more than extension, but I don't think it feels great really any way you move.
Well, which pain? Because they'll have what? They'll have lumbar pain
Yeah,
potentially,
lower
right?
back pain and then neuropathic pain as well.
And neuropathic
potentially.
pain into the
Yeah.
legs. So if you bend forward, which one is more likely to get worse?
Probably neuropathic pain if
Yeah.
you're
Yeah.
pushing it out further and irritating that nerve more.
Yeah, so I wouldn't look at it from a perspective of pushing the protrusion out further. It's more you're taking this nerve and you're pulling it tight over the top of that
Sure.
protrusion.
So more
right?
like
It's
a slump
basically
test
just
type of thing.
friction rubbing over it.
Gotcha. Okay, yeah, I mean, they may potentially again kind of keep that shift when they sit if they're very uncomfortable.
If they're willing to sit.
If they're willing to sit, yeah. It could be traumatic, but probably isn't. A lot of the time it kind of just happens over time. Yeah, I think that's all I can think of.
Yeah, so you're pretty close to nailing this down here. There's a few other things that we would obviously be able to notice, right? So most of these patients don't want to sit, right? Especially if it's acute, because that flexes the back. That's going to, like we mentioned, bending forward. It's going to irritate that dura, that nervous tissue, right? So we could potentially have neurological signs. They could complain of paresthesias or loss of sensation, weakness, right? Which would tend to be the case, especially once we get to objective testing, and then probably reflex deficits that would also come along with the radiculopathy that's associated with that. Typically, with a typical posterolateral protrusion, they're going to deviate away from the side of the injury, right? So if I have it on my right side here, I'm going to typically have that antalgic posture away from that. The idea being that we don't want to increase the amount of compression on that irritated disc tissue, right? So in most cases, disc lesions like this, posterolateral protrusions like this, are caused by either weakening of the annular fibers or some sort of end plate lesion, right? So a fracture of the end plate would actually create a significant inflammatory reaction, right? And so the hydrostatic pressure that builds as that inflammation kind of fills up that enclosed space can often be the thing that actually produces more pressure than the actual structure of the disc, right? So if we have a lesion, let's say you mentioned L5, a lot of times the nerve root actually exits the foramen very high, so right underneath the pars. And so the disc is actually down lower. And so a lot of times, unless the disc is pretty, pretty significantly damaged, it's not just the thought that, hey, this thing's popped out and it's poking into the nerve root, pressing into the dura and potentially into the encapsulated nerve there. It can just be the inflammation pressure, the pressure from the inflammatory exudate that's causing the neuropathic pain, that's sensitizing the dura, because it's a chemotaxic event, right? So it sensitizes that tissue. So that sort of stuff can be possible. Earl Pettman actually at one point suggested that an L5 disc protrusion isn't capable of producing an L5 radiculopathy because the nerve root is too high. I don't tend to really agree with that in most cases. I do think that a lot of times you can get pressure from the disc itself. But his suggestion was just what I've been talking about, the potential that it's more inflammatory related versus mechanically irritated, if that makes sense. But yeah, so I would say you'd also have worse pain in the lumbar spine when you go into extension positions. Okay, so when you go into an extended position, again, if we have, say, an end plate lesion, all you're doing is you're compressing that end plate lesion, right? So it'd be the same thing if you had, tissue damage to the ulna here at the elbow. You put pressure on it, it hurts, right? You bump your knee on something and then you press on it again, it hurts. It's bruised, it's irritated, the tissue is potentially damaged. So same sort of idea here. If we go into extension, we're likely to irritate the local disc tissue. If we go into flexion, we're more likely to irritate the irritated neuropathic tissue, neurological tissue. Okay. One thing that I always like to mention with this is dural tissue is not neurologic tissue. Okay. Dural tissue is connective tissue. So it's not capable of producing neuropathic pain or lancinating pain. It is capable of producing radiating pain if it has been sensitized by inflammation. Okay. But that's, again, part of the structure here is we're assuming that especially with an acute lesion, there's going to be inflammation associated with that. And that's what's going to give us a lot of this discomfort, is that hydrostatic pressure from the inflammation. Okay. What else do I want to mention about that? So when we're looking at kind of still playing off that idea from the hydrostatic pressure, so from that inflammatory pressure, this is why the treatment of choice for a PLP, a posterior lateral protrusion in the lumbar spine, is prone extension, right? We lay a patient on their belly, we try and prop them up into a position where they get into lumbar extension. What this does is we have increase in that hydrostatic pressure to overcome the osmotic pressure of the inflammation, right? So what does that mean? Basically, we're squeezing that inflammation so that it actually flushes that fluid back into the vertebral spongiosa, or the drainage mechanism, the venous drainage mechanism and lymphatic drainage mechanisms of the spine, right? So if we're able to do that and we're able to squeeze some of this inflammatory exudate away from that chemically sensitized dura or that potentially irritated neurological tissue, we can centralize the symptoms, right? And centralize obviously means we're getting the pain out of the leg, right? Because that's really our primary concern here, is when we have radiating pain into the periphery and potentially neurological symptoms going along with that, sensory loss, reflex loss, motor loss, we've got to fix that as fast as possible, because the longer those sort of symptoms, those sort of signs, I guess we should say, because they are actually testable, objectively testable, the longer those things linger, the more likely they are to have permanent damage of that neurological tissue, right? And that's obviously a big deal, right? So that's kind of the mechanism that we're looking to use with that prone extension, is trying to flush that out of the system. Now, it's definitely possible to have a severe enough injury to the disc where this prone extension actually makes the symptoms worse, the peripheral symptoms worse. So we have to kind of gradually move them into these positions in order to ensure that we're not, you know, increasing pressure, increasing compression. A substantially damaged disc could still create, it's still a space occupier, right? So it's still going to take up room within that neural foramen. So as we go into extension, if we have a typical neural foramen that should be this big, but we've got this big lump of disc tissue that's taking up space in that foramen, if we go into extension, we're obviously going to close that down more, right? But again, that's a degree of injury type of thought process where we have to think about that from a perspective of, do we peripheralize these symptoms or can we centralize these symptoms? Most patients with disc injuries prefer to be standing because it's closer to an extension position, right? So it's going to help to flush that fluid out of there. Anyway, that's just a thought process that we have to take when it comes to these sort of situations. Any questions about that?
I actually do have a question, Eric. Not
Yep.
not necessarily about that, but so what ages do you typically see like a true disc herniation at? Because I have more people with, you know, radiating pain and or neuropathic pain, and they're generally older. And I know that you kind of talked about how, you know, those discs kind of just, you know, that degeneration process starts pretty early on. So I'm just curious, like what the age range is or what you would typically expect to see, you know, from somebody who has, you know, those symptoms.
Yeah, so you can have it really at any age. I will say that the younger you are, the more severe the inflammation would be with disc trauma. Okay, and the reason is that the disc is more patent. It's healthier, right? So when we have, say we have a situation where we have an end plate fracture, an end plate fracture will start to leak blood into the disc. Okay, and the blood is, again, it's a very chemotaxic mechanism that starts to destabilize the nuclear material within the disc. That allows the nuclear material to herniate. It allows it to transition through the annular fibers if there's you know, damage to those fibers, if there's essentially a pathway for it to move through. So you would tend to get more severe reactions the younger the patient is, just because the proteoglycans and et cetera, all the different proteins that are making up the disc are healthier at that age. But as you get older, and these things start to break down, which is pretty normal. I mean, it tends to start happening, you know, by the age of 30, where you start to see some of these. You don't want to call them degenerative breakdown, right? Because degenerative implies that there's some sort of pathological process. This is a normal aging process that occurs. If you think of the meniscus that goes, or the disc that's in the AC joint, it's really at younger ages, up to about the age, what is it, 24, 25-ish. It's really an actual articular disc. Once you get past that, it becomes much more fibrous and basically allows the tissue to break down and become more stable. And the thought process is that by the time you get into, you know, early adulthood, it helps the shoulder blade follow what the clavicle and what the arm are trying to do more appropriately. And it really stabilizes the joint. Same sort of idea happens with the SI joint. It happens much earlier in life, usually around the age of 12, 13, something like that, where that fibrocartilaginous pad starts to become more fibrous, right? And becomes less of an intra-articular ligament and becomes more fibrous. And again, it stabilizes the joint when it does that. So it's the same sort of idea with the disc material, at least in my opinion, where we're going to start to get this kind of fibrous breakdown. But it's a normal part of aging when that happens, right? Pathology only occurs when there's more structural damage than what would be normal for that particular age. So if you get, you know, somebody into their 50s, 60s, and they, you know, aren't very healthy, they don't, you know, they aren't very strong, they've had prior lumbar issues in the past, things of that sort of nature, it's easy to break down the disc in a non-physiologic mechanism, right? Where we can have breakdown that's not due to common aging, right? So in that sort of situation, they typically will have the same sort of response because it's still irritation of the neurologic tissue, potential, you know, the inflammation won't be as bad, But at that sort of situation, you may be getting more of that true mechanical irritation of the nerve at that stage. Does that make sense with how that process kind of works?
Yeah, yeah, definitely. Thank you. I kind of, not that I had it in my head that older people couldn't get it, but
Yeah.
I just wanted to, I don't know, just clear that up just because I've been seeing a little bit more of it recently and I want to just make sure I'm thinking about it right. So thank you.
Yeah. And the good news about disc injuries is that it's very similar to like the ankle mortise. When you compress the disc, what you do is there's actually a stimulation of, God, what's the term that I'm looking for here in my head? Um, you improve the tissue quality of the annular ring, right? So we can actually help to synthesize increased um, collagen formation within the disc with compression. So even if you have an old, non-treated or residual disc lesion, you can help those patients with those things by improving compression through the disc. So it's the same, like I said, same sort of thing as what we have with the ankle mortise, is you compress those two bones together, and we'll get some of that collagen formation to kind of kickstart and help to stabilize that tissue. So same sort of idea here. It's still worth doing extension-based exercises if you can get away with it without peripheralizing the symptoms, right? Because obviously if you peripheralize symptoms, you have them doing extension-based stuff and they say, you know what, I feel that going down the back of my leg. And we don't want to do that. We want to get things centralized. We want to get things out of the leg. So it might be a situation where you have to do some of that extension by hand, right? You just lay them down, you do mobilization right into an extension quadrant there, where you can kind of manually control how much pressure is going through that without, again, irritating anything and peripheralizing any of these symptoms. And again, most of the time, these aren't going to be true neuropathic pains if they're old disc lesions, things that have kind of healed up previously but didn't really have any particular treatment. These things just kind of lurk around, and all they are then, they're just a mechanical block, right? They're just working, getting in the way. It's like if you stick a pencil eraser in the way and they kind of come down squeezing on that tissue, it's not necessarily going to give very well, right? But because you have this collagen tissue stuck in between the two bones impeding that motion. But we can work on those sort of things, and it's probably more dural tissue that's causing the reference at that point. Has the same reference as the nerve because it follows the nerve, but it doesn't have the same quality to it, right? It has more of that somatic feel to it. And that's a lot of times when I'll talk to patients about these sort of issues, they come in, they say they've got sciatica, and I'm asking, okay, well, so when you sit down, when you bend forward, tie your shoes, things like that, you're getting a lightning bolt down their leg. And they're like, no, it's usually, if I'm sitting for long periods, if I sit on a plane or if I'm sitting in a car for a long time, or if I'm at my desk for too long, then I start getting some aching pain going down the back of my leg. Well, that's not true sciatica. True sciatica is the neuropathic pain that we've been talking about. Those, instantaneous, you move and zing, there it goes right down the leg. That's a true sciatica. So I tend to break it up into two different things here, at least in my head, where I have a neuropathic sciatica, and then I have a somatic sciatica, right? And so somatic sciatica is the type that most people come into your office with, where they've got that dull, achy pain that's kind of in and out with activity or with a positional change or something of that sort of nature. But the dura can certainly cause that sort of thing if it's been previously sensitized, or if there's some sort of pressure on it from, some sort of old disc lesion, something like that. So we have to take those things into consideration, and realistically, from a biomechanical and a pathoanatomical standpoint, we have to be able to consider those sort of thought processes. Got time for maybe one more question here before I have to split and get on the road. But what would happen if we had a patient that would reproduce lancinating pain with trunk rotation instead of flexion or extension? What do we think might be happening there? Anybody got a thought?
You say it again.
Yeah, so the patient has lancinating leg pain. Let's just say it's the right leg, but they have that lancinating leg pain with trunk rotation as opposed to trunk flexion or extension. Any thoughts what might be going on with that person?
I look at rotation, Eric, as very stressful to the disc as well. So I don't necessarily always need flexion. So yeah, I actually a lot of times won't even have them go through rotation if they're even remotely acute. A lot of times we'll skip it. But if in fact they happen to do that, that kind of leans me more towards a hot disc. Those annular fibers, they alternate in direction and they become taut,
Yep.
right? When we rotate, those wind up. So it tells me there's probably been an injury to the actual structure of the annular fibers if that is eliciting pain.
Well, but here's the deal. The annular fibers also become taut in flexion, right? And if flexion's not reproducing pain, then can we expect that it's still the disc?
You are correct. That's inconsistent.
Yeah, and inconsistency should give us pause, right? If we can't explain something, we have to think about what else might be going on here. So let me ask you this. Let's say that this patient first developed this pain after going to a chiropractic appointment. Immediately after a chiropractic appointment.
I think some kind of joint trauma, potentially facet joint irritation.
Yeah, so
he just rammed right through it.
What do chiropractors like to do? They like to do big rotational manipulations to the lumbar spine, right? They throw the leg over the table and they jump on it and all this sort of stuff. So big rotational trauma, potentially, especially if it comes on immediately. The thing that I would be most suspicious of, especially if they have lancinating pain down the leg, is I'd be looking at a neural arch fracture. So fracturing of the pars or the pedicle potentially would be the most likely thing for me, right? And so this nerve, we've got this foraminal space here, and we've got this portion of the arch is a fracture right through that as that nerve goes right underneath it. That would be the thing that would concern me most in a patient that's painful with rotation, but not with flexion, is some sort of bony lesion. Does that make sense? Because that's going to change our treatment protocol, right? Extension is no longer going to be the best treatment. We need to fixate this person. This person needs to be put into some kind of corset, some sort of brace to prevent them from rotating, to allow that fracture to heal. We all okay with that?
Is that something, if you're suspicious of it, you would probably want to have them x-ray just to double check? You probably
Oh,
don't
yeah.
want to just rely on your assumption with something like that, correct?
Well, the thought process is my treatment would be the same. I'd still want to immobilize this person, prevent them from getting into that position. But yeah, I'd want an oblique angle x-ray to look for a pars fracture. Because essentially it goes back to that thought process. If I can't specifically diagnose a problem, right? If I can't specifically look at something and say, this is what I think it is, and this is how I would go about treating it, those inconsistencies mean I shouldn't be doing a lot of treatment with this person to begin with, right? Because what am I treating? If I don't have a good hypothesis as to what I'm actually looking at to treat, I shouldn't be going into doing a bunch of treatment at that stage, just because if I don't know, I might make it worse, without intentionally doing so. So you can give them some things that maybe they can do at home. Maybe they can, maybe to help with core stability, et cetera. But we're looking mostly at palliative things here, right? See if we can eliminate some of the lancinating pain. See if we can help to stabilize some things. But yeah, you're going to want to get some imaging done here to confirm what you're suspicious of. But it's the same thing with any fracture, right? If you look at somebody that's had a trauma and you're just like, well, I'm concerned that there might be bony damage done here. They might actually have a fracture here. Isn't that a red flag anyway, as far as manual treatment goes? It is, right? So we wouldn't necessarily jump right into trying to treat this person, just because, especially with manual therapy, just because we don't really know what's going on in there from a structural perspective. All right, guys, I hate to be that guy and dump you guys a little early, but we gotta run because we got to get out of town here. So, any questions in particular? If you have anything about it, feel free to either email me or write it down. We can talk about it again next week. Okay, so hopefully we'll get a chance to catch up then. Hopefully Dave will be back and we'll have some other stuff we can talk about. All right.
Thanks, Eric.
Yep, you bet, guys.
Thanks,
Have a
Eric.
good week.